Are you okay? Marty.
Are you choking? I'm an emergency responder. May I help you?
Todd. Todd.
Do you need help?
Todd.
Kevin, are you all right?
Jimmy, come here quick. Call emergency medical services immediately.
Susie, go call for help.
My neighbor just collapsed. Can you please send someone over?
My name is Eileen. I'm an emergency responder. May I help you?
Are you okay?
Medical emergencies and accidents happen every day.
Hey, Susie, can you call for help? Bring a first aid kit. Kevin, it's Steve.
At home, while commuting, at work, and during recreation. They're an unfortunate but inevitable part of life. Usually the first person to help is a layperson, friend, co-worker, or passerby. Someone like you. There are no guarantees, of course, but by applying some basic knowledge and skills as an emergency responder, you can do everything reasonably possible to produce a favorable outcome for the patient. You learn these basic skills in the Emergency First Response Primary Care, CPR, and Secondary Care, First Aid courses. Emergency First Response Primary Care, CPR, prepares you to aid patients with life-threatening emergencies. You learn the same emergency care priorities medical professionals use. Emergency First Response Secondary Care, First Aid, builds upon what you learn in the Primary Care course. In that course, you learn to give aid for medical emergencies that aren't immediately life-threatening. The Emergency First Response courses follow the protocols of the Basic Life Support Working Group of ILCOR, the International Liaison Committee on Resuscitation. This group represents the world's major resuscitation organizations. Although Emergency First Response is an internationally based course, local variation in skill technique, first aid procedures, terminology, requirements, and course flow may exist. Your Emergency First Response instructor will guide you. In Emergency First Response Primary Care, CPR, you learn 8 essential skills that link together when you help someone in a life-threatening emergency. Scene assessment, barrier use, primary assessment, CPR, rescue breathing and chest compressions, conscious and unconscious choking adult, serious bleeding management, shock management, and spinal injury management. You may also learn other recommended primary care skills such as automated external defibrillator use and emergency oxygen use. In Emergency First Response Secondary Care, First Aid, you learn what to do when emergency medical services are either delayed or unavailable. Secondary care skills include injury assessment, illness assessment, bandaging, and splinting for dislocations and fractures. This video covers the skills for both courses. After watching the skills in the video, your instructor will demonstrate them for you in class. Then you'll practice the skills. After you've learned to perform and sequence the skills, you'll get to practice them in simulated emergency situations. This teaches you to adapt your emergency responder skills to real emergencies.
Are you okay?
A medical emergency arises. As an emergency responder, you know that if you assist, you can save or restore a patient's life. You can reduce a patient's recovery time. And you can make the difference between a temporary or lifelong disability. But even knowing this, sometimes people hesitate to help, even people with CPR and first aid training. They may feel anxiety or guilt about the situation. Sometimes they're afraid they'll do the wrong thing. In some societies, people are afraid they'll get sued if the situation doesn't work out right. And there's the fear of communicable diseases. As an emergency responder, realize that none of these concerns need prevent you from helping in a medical emergency. Let's look at why. First, let's look at the fear of infection. You may hesitate because you are afraid of being infected by the person you are assisting. This is a concern, but remember your training includes learning to use protective barriers to minimize the risk of disease transmission. By using barriers, you're highly unlikely to get any disease or infection from someone you help. Second, focus on helping, not perfection. You want to do the best you can, but it's unlikely a minor error will make much difference, much less hurt or kill a patient. Focusing on perfection tends to make people hesitate in a real emergency. Do not hesitate. Help. Remember, adequate care provided is better than perfect care withheld. Third, learn to trust your training. During the scenarios, you'll find that what you think you forgot comes back when you provide aid. At first, things feel awkward. Then suddenly you've got it, like getting back on a bicycle after not riding one for years. Remember this feeling. You can trust it in a real emergency. Fourth, be decisive and act. Usually there's more than one right way to handle a situation. Circumstances don't always provide clear direction. Start helping immediately. To help you be decisive and act, Emergency First Response has developed an easy-to-use prompt to remind you of the important steps needed to assist someone in need. The Emergency Care at a Glance Decision Guide provides you with comprehensive primary and secondary care directions. This is a must-have addition to your first aid kit at home and on the road. Fifth, you may be concerned about your responsibility when helping another in need. You may hesitate because you're afraid of being sued. In general, the fear of being sued should not stop you from providing emergency care. Many countries have Good Samaritan laws which simply say that as a layperson helping another, you cannot be successfully sued if ultimately things don't work out well for the patient. Your training in this course will show you how to provide help within the protection of these laws. Good Samaritan laws will generally protect you if you provide care within the scope of your training as an emergency responder. Ask for permission to help. Act in good faith. Are not reckless or negligent. Act as a reasonably prudent person would. And don't abandon the patient once you begin care. The exception is if you must do so to protect yourself from imminent danger. Finally, don't worry about making a person worse. The most serious medical emergency is when a patient isn't breathing and has no heartbeat. Sometimes people hesitate to help such a patient, fearing they'd make him worse. As an emergency responder, realize you cannot make such a person worse.
Hey, Kev. Susie, go call for help.
Okay.
Hey, Kevin, are you all right? Kev, it's Steve. Can you hear me?
A person who isn't breathing and has no heartbeat is already in the worst state of health. Again, remember you cannot make the person worse, but you may be able to help this person. You don't need to fear providing rescue breaths and chest compressions. You can trust your training. Take a moment to relax, think of your training, then step forward and help. CPR, cardiopulmonary resuscitation, helps to oxygenate the body when the heart isn't beating. You do this because if CPR begins soon enough and if emergency care arrives quickly, then it may be possible to restart the patient's heart. CPR won't usually restart the patient's heart. Instead, it extends the period during which it may be possible to restart the heart.
Nice move.
Take it.
Take that shot.
Take it.
Todd. 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 Todd, it's Richard.
Realize that CPR doesn't guarantee that the patient's heart will restart. In fact, most of the time, even with CPR, it doesn't restart. This means that you can never know whether providing CPR or any other aid that's called for would have made a difference unless you step forward and provide help. If you provide CPR and the patient's heart doesn't restart when medical care arrives, realize that you did everything humanly possible. But if you could have provided CPR and didn't, you may spend the rest of your life wondering whether it would have made a difference. Don't let that happen. Trust your training and help. Remember, adequate care provided is better than perfect care withheld. While you are taking this course, don't be intimidated. Naturally, you'll make mistakes during the course. It's a normal part of learning. So if you make one, just adjust and try again. If you already knew what to do, you wouldn't be taking a course. You'll have plenty of time to practice, build your confidence, and be ready to help someone in an emergency. Also, have fun. That may sound odd considering the seriousness of what you're learning, but you'll learn more and learn faster when you enjoy the learning process. Keep it light. Your ability to use a skill effectively weakens when you don't use it for a while. But once you've learned it, it comes back much easier than learning it the first time. The more recently you practice a skill, the easier it comes back. The same is true for your emergency first response skills. Hopefully you won't need them often in real emergencies, so you want to practice to keep them fresh. Here's how. First, watch this video from time to time so you remember the skill steps and the information that relates to using them. Second, run through practice emergencies with other emergency responders in your family or among your friends. Try to get some CPR practice. If you don't have a CPR mannequin, use a stuffed sack that's the right size or even a pillow, but never practice CPR chest compressions on a person. Doing so can interfere with the person's normal heartbeat. Finally, refresh your skills with an instructor in the Emergency First Response Primary Care (CPR) and Secondary Care First Aid refresher at least every 2 years, but refresh more often if you can. When you complete the update, you receive a current Emergency First Response completion card. When you recognize a potentially life-threatening emergency, you help with the first 3 links in the chain of survival. Link 1 is early recognition and call for help. Link 2 represents early CPR. The third link is early defibrillation. The fourth link, early professional care and follow-up, is for professional health care providers. In a life-threatening emergency, early professional care is very important. The sooner emergency medical professionals arrive, the better the outlook for the patient. The emergency responder does not replace professional emergency medical care. In the chain of survival, your role as the emergency responder is to summon emergency medical aid and to assist the patient until it arrives. Activating EMS is so important that in most circumstances, if you're alone and there's no one else to activate the EMS for you, you call first, then assist the patient. An exception to the call first rule is if the patient is a child or an adult that has experienced submersion in water or other incident that is likely to be a respiratory-related event. In these cases, you provide CPR for about 2 minutes, then call emergency medical services. An exception to the call first rule is if the patient is a child or an adult that has experienced submersion in water or other incident that is likely to be a respiratory-related event. In these cases, you provide CPR for about 1 minute, then call emergency medical services.
13, 14, 15, 16, 17, 18, 19, 20, 21, 22. Take this arm and grab your other hand.
With EMS on the way, the care you provide increases the chance that advanced care will help the patient when it arrives. Your training in this course is based on handling emergencies where you have an emergency medical system. If you need to provide emergency aid in areas away from EMS support, you should continue your education with more advanced first aid training.
Check your abdomen now.
Providing emergency care can be very stressful. After the incident and after the emergency medical professionals take over, it's time to take care of yourself. You may wish to talk about the event to a friend or family member. You may find the situation upsetting, especially if things didn't work out well for the patient.
Still, I feel like I let him down. I mean, what about his family? I feel like I let them down too.
Talk to someone if it helps, including a healthcare professional if necessary. But remember that as an emergency responder, your training only gives those you help the best chances possible, not promises nor guarantees of medical miracles. No matter how it works out for the patient, feel good about the fact that you reached out to help another.
All right. Maybe you're right. Maybe doing something is better.
Before helping someone, it's important to ask for permission to help. You do this with the responder statement.
Okay, I'm an emergency responder. May I help you?
Yes, please.
You simply say, "Hello, my name is," your name. "I'm an emergency responder. May I help you?" It's important to get the patient's agreement if he is alert and responsive. If a patient is unresponsive, give the responder statement anyway.
I'm an emergency responder. May I help you?
If the patient can't answer, most laws assume implied consent. This means the law recognizes that in a serious situation, the patient would almost certainly want help. Laws vary from one region to the next, so check those that apply to you. If an adult refuses your help, don't force it on her. Instead, talk to the person, stressing the need for care and monitor her condition without providing actual aid. Depending on the situation, however, you could activate EMS at this time. Have you ever wondered how medical professionals know what to treat first when they help someone? They monitor the ABCDs of the patient's lifeline, which provide the sequence for helping the patient. The ABCD sequence of emergency care will help you remember what to do. You'll practice monitoring the lifeline and the ABCDs as you learn emergency first response skills.
May I help you? Steve, can you hear me?
A stands for assess the scene. Alert emergency medical service. Apply personal barriers. And assure the airway is open so the patient can breathe. B stands for breathing. With the airway open, you check that the patient is breathing, and if needed, begin rescue breaths. C stands for circulation and chest compressions, prompting you to begin chest compressions if a patient has stopped breathing. The chest compressions artificially circulate blood to vital organs. D is for defibrillation, the process that attempts to restart the heart. You'll learn more about defibrillation a bit later. S reminds you to apply serious bleeding management, shock management, and spinal injury management. When you come across a possible medical emergency, what's the first thing you do? It may surprise you that the first thing you do is think about yourself. You need to protect yourself. This is for the sake of the person needing help as well as for yours. After all, if you get hurt, you can't help. Assessing a scene, one of the A's in the lifeline, is the process of looking for and avoiding any dangers at the scene of a medical emergency. It's the first thing you do and the first skill you'll practice. Scene assessment takes 3 steps. 1. Stop. 2. Think. And then 3. Act. Stop and assess the scene for hazards. What hurt the person? Can it hurt you? Watch out for traffic, especially if helping around an auto accident. Be wary of the unseen, like fumes, electricity sources, chemicals, or radiation. Beware of spreading fire, not just because it burns, but because smoke inhalation can injure, incapacitate, and even kill. After you're sure the scene is safe, take a moment to think about what to do next. After surveying the scene quickly, ask yourself, what emergency care might be needed? If there's more than one patient, who appears to need help the most urgently? What can you reasonably expect to do? How do you activate the emergency medical service where you are? Now act. In a readily apparent serious emergency, first activate the local emergency medical service, either yourself or by having an able bystander do so. This is the cool first approach to emergency care.
Okay, I'm gonna go to him now.
Now act. In a readily apparent serious emergency, first check the patient's breathing. If no breathing is detected, activate the local emergency medical service, either yourself or by having an able bystander do so. This is the cool first approach to emergency care.
Okay, I'm gonna go to him now. As soon as possible. I'm at Reef Point.
If you make the call, it's best to stay on the line until you hear the emergency operator hang up. That way, you won't accidentally hang up before the operator gets all the necessary information. In some circumstances, the need for medical care may be in question, so you would activate the emergency medical service after or during your primary assessment based on what you find. As you help, follow the emergency first response skill sequence, but scene assessment and taking care of yourself never stops. Ensure your safety so you can help others in need. Earlier, you learned that some people fear infection and therefore hesitate to help others in medical emergencies. The diseases of most concern are those transmitted through blood and other body fluids. These are hepatitis B and C and the human immunodeficiency virus, or HIV. As an emergency responder, you can greatly reduce infection risk by applying barriers, another one of the A's in the lifeline. Barriers include gloves, ventilation masks or shields, face shields, and eye shields. You can minimize the risk of infection by always placing a barrier between you and any body fluid of another person. Like scene assessment, barrier use is a skill that usually comes before you start helping the patient. Remember, to start with skill 1, scene assessment. Stop, think, and act. First, you'll put on gloves. Put the glove on carefully to avoid tearing. Remove gloves so that you don't spray or spread body fluids. Carefully loosen the first glove at the wrist and roll it inside out into a ball. Hold it in your gloved hand, then roll off the remaining glove by lifting at the wrist from inside, like this. Use caution not to tear the gloves or snap them, which can spray body fluids. Place the gloves in a biohazard bag for disposal according to local guidelines. Your instructor will show you how to use one or more of the different ventilation barriers available. They all trap or isolate you from moisture or fluids from the patient's breath and mouth, allowing you to provide rescue breathing and CPR with minimal infection risk. Barriers take up little room, so it's easy to keep a set of gloves and ventilation barriers handy. Try to keep one or more sets so they're nearby at all times, but they're not required to provide CPR. The risk of infection is minimal and may be even lower if you're helping someone who has a medical history you know, like a family member. This is your decision, but you may decide you don't need to withhold aid just because you don't have a barrier available. You've assessed the scene, activated the local emergency medical service, and applied your barriers. Now you're ready to begin primary assessment. You've assessed the scene and applied your barriers. Now you're ready to begin primary assessment. Primary means first and most important. Primary assessment is your first and most important evaluation of the patient. During the assessment, you evaluate the patient for life-threatening conditions that need immediate attention, and you determine the priorities you need to follow. No matter what the patient's situation when you arrive, you begin with primary assessment, following the ABCDs of the patient's lifeline. Throughout the incident, you continually monitor the lifeline, ready to provide assistance based on what it tells you. Watch this emergency scenario, noting how the ABCDs guide the rescuer. After the scenario, we'll review how the rescuer applied each step.
Marty, are you okay? Marty, it's Tina. I'm an emergency responder. May I help you? Marty! Marty! Hello, my name is Tina. I'm at 5746 Michael Street. Yeah, my neighbor just collapsed. Can you please send someone over? Thank you.
The Lifeline ABCDs answer all questions about what conditions to treat first. For instance, suppose a patient has serious bleeding and doesn't appear to be breathing. What do you do first? First, you go to A and assess the scene. Alert EMS. Apply personal barriers and open the airway. Then you go to B and check for breathing. You find the patient isn't breathing, so you breathe for him and give 2 rescue breaths. At step C for circulation, you immediately begin chest compressions. Rescue breaths and chest compressions, CPR, takes priority over serious bleeding. The Lifeline ABCDs lead you correctly to deal with the absent heartbeat before you deal with serious bleeding. Watch this emergency scenario, noting how the ABCDs guide the rescuer. After the scenario, we'll review how the rescuer applied each step.
Marty, are you okay? Marty, it's Tina. I'm an emergency responder. May I help you? Marty? Marty? Hi, my name is Tina. I'm at 5746 Michael Street. My neighbor just collapsed. Can you please stop?
The Lifeline ABCDs answer all questions about what conditions to treat first. For instance, suppose a patient has serious bleeding and doesn't appear to be breathing. What do you do first? First, you go to A and assess the scene. Apply personal barriers and open the airway. Then you go to B and check for breathing. If you find the patient isn't breathing, alert EMS. At step C for circulation, you immediately begin chest compressions. Rescue breaths and chest compressions, CPR, takes priority over serious bleeding. The Lifeline ABCDs lead you correctly to deal with the absent heartbeat before you deal with serious bleeding. Let's look at primary assessment first with a responsive patient and then with an unresponsive patient. A responsive patient is one who is alert and able to answer questions. Begin with assess the scene. Stop, think, and act, and apply personal barriers. Sometimes you can don your gloves as you approach the patient. Next, give the responder statement. Hello, my name is your name. I'm an emergency responder. May I help you?
My name is Robin. I'm an emergency responder. May I help you?
Do not move the patient unless there's an immediate threat to you or the patient's safety. Because a responsive patient is talking, you verified an open airway, breathing, and circulation, ABC, of her lifeline. Check for and treat serious bleeding. Treat for shock and treat for spinal injury. Again, without moving the patient. As you monitor the lifeline, alert the emergency medical service if and when you find any serious medical condition. Now let's look at primary assessment with an unresponsive patient. An unresponsive patient is one who is either completely unconscious or one who may be partially conscious but incapable of rational responses. Begin with assessing the scene. Stop, think, and act. Apply personal barriers. Put on your gloves. Perform your assessment with the patient in the position you find him. First, give the responder statement.
Hello? My name is Eileen. I'm an emergency responder. May I help you?
You do this even with an unresponsive patient because he may still be able to hear you. If the patient doesn't respond to your statement, then tap him on the shoulder to further check responsiveness. While tapping the patient, you may ask, "Are you okay?"
Are you okay? Are you okay?
The patient does not respond, so have someone alert the emergency medical service or do it yourself if you're alone. This is the call first approach to emergency care. You call first to activate emergency medical services, then you provide assistance. Next, open the airway using the head tilt chin lift. While lifting the bony part of his chin with your fingertips, put your hand on the patient's forehead and gently tilt his head back, like this. The patient does not respond. So open the airway using the head tilt chin lift. While lifting the bony part of his chin with your fingertips, put your hand on the patient's forehead and gently tilt his head back like this. Do not tilt the head or turn it from side to side. Hold the airway open and conduct a breathing check. Look, listen, and feel. Watch for the chest to rise and fall. Listen for breathing and try to feel his breath on your ear. Do this for no more than 10 seconds. This patient is breathing, so there is no need to determine if he has a heartbeat. A breathing patient has a heartbeat. If the patient were not breathing, you would immediately provide the patient with 2 rescue breaths and then move to C, circulation of the lifeline, and give chest compressions. You'll learn the details for rescue breaths and chest compressions when you learn Skill 5, One Rescuer Adult CPR. Finally, you would check for and treat serious bleeding, shock, and spinal injury. After your primary assessment, you normally put a breathing, unresponsive patient in the recovery position. This decreases the risk of something blocking her airway and allows fluids to drain should she vomit. Keep the patient's head stable, in line with her body. This way, if there's an undetected spinal injury, you won't make it worse. Put the patient on her side. Put her lower arm near or under her head to keep her head in place. Use her upper leg to hold her in place. Continue to monitor her lifeline. If during your primary assessment you discover that the patient isn't breathing, then they need CPR, cardiopulmonary resuscitation. CPR is a 2-step process. Step 1, rescue breathing, is followed immediately by Step 2, chest compressions. To begin CPR, you'll breathe for the patient, inflating the lungs and providing oxygen. This works because we use only a small portion of the oxygen in each breath we take, leaving ample oxygen to support life in each exhalation. If the heart isn't beating, rescue breaths alone don't benefit the patient. After you breathe for the patient, then you press on the chest to artificially pump the heart. Doing so is called chest compressions. Chest compressions work by moving blood with oxygen through the body to vital organs even when the heart has stopped. CPR is an emergency measure that can extend the window during which it may be possible to restart the heart. However, it only circulates about 1/3 as much blood as the heart, and it's difficult to sustain for long periods. Even with CPR, the sooner one attempts to restart the heart, the more likely it will restart. This is why it's important that emergency medical personnel arrive quickly and provide advanced cardiac life support, such as drugs, artificial airwaves, ventilation devices, and defibrillation. Defibrillation is the process of restarting an erratic heart. Natural electrical impulses control your heartbeat. When these impulses fail, the heart beats erratically and no longer pumps blood. This is called fibrillation or twitching. Defibrillation administers a shock that momentarily disrupts the erratic signals and allows the normal heartbeat to return. As time passes, the probability of defibrillation restoring the heartbeat goes down. It is rare for a heart to resume beating without defibrillation, even with CPR. The benefit of prompt defibrillation was the reason for the development of automated external defibrillators, or AEDs. AEDs are defibrillators designed for use by lay emergency responders. AEDs electronically monitor the need for and administer a shock. Your instructor may provide AED instruction as part of this course.
Clear of patient.
I'm clear, you're clear.
Deliver shock now.
This is how CPR is delivered. Begin with assessing the scene. Stop, think, and act. Apply your barriers. Next, give the response statement, asking permission to help.
Hey, this is Leroy. I'm an emergency responder. Can I help you?
If the patient doesn't respond to your statement, then tap him on the shoulder and ask,
"Are you okay? Kenny?"
If the patient still does not respond, have someone call the emergency medical service or do so yourself if you're alone.
Help, please.
Next, open the airway as you've learned, using the head tilt chin lift. Look, listen, and feel for breathing for no more than 10 seconds. Periodic gasping is not normal breathing. If you hear a patient gasping, go ahead and immediately begin rescue breaths. Mistaking these gasps for actual breathing could mean not giving CPR and rescue breaths when you should. Therefore, it's important not to confuse these occasional gasps with normal breathing. This patient isn't breathing, so put her on her back if she's not already in that position. Put a ventilation barrier in place. Pinch or block the patient's nose closed. Next, give 2 rescue breaths, with each breath taking about a second. By delivering a normal breath, not a deep breath, the patient's chest should rise and fall. If you can't make the patient's chest rise with the first breath, repeat the head tilt chin lift to open the airway before attempting another breath. Improper position is the most common cause for not being able to inflate the lungs. Don't try more than twice to give rescue breaths that make the chest rise, because it's important to give chest compressions. After 2 breaths, whether they make the chest rise or not, you will begin chest compressions.
6 and 7 and 8 and 9, 10, 11, 12, 13, 14, 15.
To begin chest compressions, expose his chest if necessary. Find the compression site by putting the heel of your hand in the chest center, between the nipples. Place your other hand on top of the first, like this. Lean directly over the patient with your arms straight and your shoulders over your hands. To provide effective chest compressions, you should push hard and push fast, depressing the breastbone about 4 to 5 centimeters, 1.5 to 2 inches. After a chest compression, release, allowing the chest to return to its normal position, and repeat at a pace of 1, 2, 3, 4, and so on for 30 compressions as fluidly as possible. This rate is about 100 compressions per minute. Now reopen the patient's airway and administer 2 rescue breaths, each lasting about 1 second. Immediately follow your second rescue breath with 30 more compressions. Do not delay chest compressions. Continue alternating 30 compressions with 2 breaths until EMS arrives, until you can defibrillate with an AED, until the patient shows signs of circulation, until another emergency responder takes over for you, or until you're too exhausted to continue.
24, 25, 26, 27, 28, 29, 30.
If you are unable or feel uncomfortable giving a non-breathing patient rescue breaths, relax. Give the patient continuous chest compressions. Chest compressions alone are very beneficial to a patient without a heartbeat. Your efforts may still help circulate blood that contains some oxygen. Remember, adequate care provided is better than perfect care withheld.
1 and 2 and 3 and 4 and 5 and 6.
With your instructor, you will practice CPR using a CPR mannequin. Remember, do not perform chest compressions on someone who does not need CPR. Let's continue to monitor the B or breathing portion of a patient's lifeline, specifically with a patient that is choking. A choking patient needs immediate help to restore breathing. In adults, the most common cause of choking is food. Let's learn how to help a conscious and unconscious patient expel an object that's choking him. If you believe a person is choking, begin with scene assessment. Stop, think, and act. Since you're not likely to have contact with body fluids and time is important, you usually do not need personal protective barriers. Ask a responsive patient,
"Are you choking?"
If he can speak or cough, encourage the patient to cough until he expels the object. If the patient cannot speak or breathe, give the emergency responder statement and alert EMS.
"I'm an emergency responder. May I help you?" "All right, take it easy. Just relax."
After the patient indicates he wants your help, you will either use back blows, abdominal thrusts, or chest thrusts to attempt to dislodge the object. To begin to assist the choking person, it doesn't matter which technique you use. There is no clear evidence which technique is better, but there is clear evidence that with many choking persons, if one technique does not work, another method sometimes does.
Take it easy. Sit down. You all right?
To deliver back blows, take a position to the side and slightly behind the patient. Supporting the chest with one hand, lean the patient forward. Next, firmly strike the person between the shoulder blades with the heel of the other hand 5 times. Stop if the obstruction clears. Abdominal thrusts use residual air in the patient's lungs to blow the obstruction clear. Stand behind the patient with your arms around her waist. Find the patient's navel with one hand. Make the other into a fist and place the thumb side against the patient's abdomen slightly above her navel, like this. Put your other hand on top of your fist. Bowing your arms so you don't squeeze the patient's ribs, pull your hands inward and upward in a thrusting motion. Repeat this until you dislodge the obstruction or until the patient becomes unresponsive. Abdominal thrusts may not be possible with some individuals, such as those who are pregnant or markedly obese. In these cases, provide thrusts in the center of the chest. Use your fist with the thumbs inward and the other hand on top, just as you do with abdominal thrusts. Put your fist on the same site where you would perform a CPR compression. It is recommended that you perform all 3 techniques, back blows, abdominal thrusts, or chest thrusts in rapid succession until the obstruction is relieved or the patient becomes unconscious. When you practice these techniques, be sure to simulate thrusting. Never perform thrusts on a person who does not have an obstructed airway. Earlier, you learned that if you can't give a rescue breath to an unresponsive patient after 2 attempts to open the airway, you begin CPR compressions. This is also what you do if a responsive patient becomes unconscious while you are trying to assist him clear his airway. If after the patient becomes unresponsive, you cannot give an effective rescue breath after 2 attempts to reopen the airway, immediately begin chest compressions. The compression should dislodge any obstruction. Following the chest compressions, you should quickly look inside the patient's mouth to see if there is any solid material visible in the airway. If an object is seen, you should remove the object with your finger. If no object is seen or the object has been removed, you should proceed with 2 rescue breaths. Finally, contact EMS or have someone do so if you've not done so already. If the patient still isn't breathing, continue to give 30 compressions followed by attempting 2 rescue breaths, just as you've already learned. This patient is breathing, so there is no need to determine if he has a heartbeat. A breathing patient has a heartbeat. If the patient were not breathing, you would immediately alert EMS.
Call emergency medical services immediately.
Provide the patient with chest compressions and then deliver rescue breaths. You'll learn the details for rescue breaths and chest compressions when you learn Skill 5, One Rescuer Adult CPR. Finally, you would check for and treat serious bleeding, shock, and spinal injury. After your primary assessment, you normally put a breathing, unresponsive patient in the recovery position. This decreases the risk of something blocking her airway and allows fluids to drain should she vomit. Keep the patient's head stable, in line with her body. This way, if there's an undetected spinal injury, you won't make it worse. Put the patient on her side. Put her lower arm near or under her head to keep her head in place. Use her upper leg to hold her in place. Continue to monitor her lifeline. If the patient has to be kept in the recovery position for more than 30 minutes, turn her to the opposite side to relieve pressure on the lower arm. If during your primary assessment you discover that the patient isn't breathing normally, then they need CPR, cardiopulmonary resuscitation. CPR includes rescue breathing and chest compressions. CPR involves pressing on the chest to artificially pump the heart. Doing so is called chest compressions. Chest compressions work by moving blood with oxygen through the body to vital organs even when the heart has stopped. CPR also includes breathing for the patient, inflating the lungs and providing oxygen. This works because we use only a small portion of the oxygen in each breath we take, leaving ample oxygen to support life in each exhalation. CPR is an emergency measure that can extend the window during which it may be possible to restart the heart. However, it only circulates about 1/3 as much blood as the heart, and it's difficult to sustain for long periods. Even with CPR, the sooner one attempts to restart the heart, the more likely it will restart. This is why it's important that emergency medical personnel arrive quickly and provide advanced cardiac life support, such as drugs, artificial airwaves, ventilation devices, and defibrillation. Defibrillation is the process of restarting an erratic heart. Natural electrical impulses control your heartbeat. When these impulses fail, the heart beats erratically and no longer pumps blood. This is called fibrillation or twitching. Defibrillation administers a shock that momentarily disrupts the erratic signals and allows the normal heartbeat to return. As time passes, the probability of defibrillation restoring the heartbeat goes down. It is rare for a heart to resume beating without defibrillation, even with CPR. The benefit of prompt defibrillation was the reason for the development of automated external defibrillators, or AEDs. AEDs are defibrillators designed for use by lay emergency responders.
Do not touch the patient.
AEDs electronically monitor the need for and administer a shock.
Shock advised.
Your instructor may provide AED instruction as part of this course.
Deliver shock now.
This is how CPR is delivered. Begin with assessing the scene. Stop, think, and act. Apply your barriers. Next, give the responder statement, asking permission to help.
Hey, this is Leroy. I'm an emergency responder. Can I help you?
If the patient doesn't respond to your statement, then tap him on the shoulder and ask,
"Are you okay?"
If the patient still does not respond, shout for help. Next, check for breathing in the position you find the patient. Look, listen, and feel for breathing for no more than 10 seconds. Periodic gasping is not normal breathing. If you hear a gasping, go ahead and begin rescue breaths. Mistaking these gasps for actual breathing could mean not giving CPR and rescue breaths when you should. Therefore, it's important not to confuse these occasional gasps with normal breathing. This patient isn't breathing normally, so send someone for help. Or if you're on your own, leave the patient and alert emergency medical services.
Bring them back here to us and hurry.
Upon return to the patient, put him on his back if he's not already in that position. Next, kneel by his side and place the heel of one hand in the center of the patient's chest. Next, place the heel of your other hand on top, like this. Interlock the fingers of your hands and ensure that pressure is not applied over the patient's ribs. Position yourself vertically above the patient's chest and with your arms straight, press down on the sternum 4 to 5 centimeters like this. After a chest compression, release, allowing the chest to return to its normal position, and repeat at a pace of 1, 2, 3, 4. Chest compression should repeat at a rate of about 100 per minute. After 30 compressions, put a ventilation barrier in place and open the airway using the head tilt chin lift. Pinch the nose close like this. Next, give 2 rescue breaths, with each breath taking about a second. By delivering a normal breath, not a deep breath, the patient's chest should rise and fall. If you can't make the patient's chest rise with the first breath, repeat the head tilt chin lift to open the airway before attempting another breath. Improper position is the most common cause for not being able to inflate the lungs. Don't try more than twice to give rescue breaths that make the chest rise because it's important to continue chest compressions. After 2 breaths, whether they make the chest rise or not, immediately continue chest compressions again without delay.
6 and 7 and 8 and 9, 10, 11, 12, 13, 14.
Continue alternating 30 compressions with 2 breaths until EMS arrives, until you can defibrillate with an AED, until the patient starts to breathe normally, until another emergency responder takes over for you, or until you're too exhausted to continue.
23, 24, 25, 26, 27, 28, 29, 30.
If you are unable or feel uncomfortable giving a non-breathing patient rescue breaths, relax. Give the patient continuous chest compressions. Chest compressions alone are very beneficial to a patient without a heartbeat. Your effort may still help circulate blood that contains some oxygen. Remember, adequate care provided is better than perfect care withheld.
4 and 5 and 6 and 7 and 8 and 9.
With your instructor, you will practice CPR using a CPR mannequin. Remember, do not perform chest compressions on someone who does not need CPR. Finally, there is recognition that delivering chest compressions is tiring. It is now recommended that where more than one rescuer is present, another should take over the compressions with a minimum of delay about every 2 minutes to prevent fatigue and maintain quality of performance.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Let's continue to monitor the B or breathing portion of a patient's lifeline, specifically with a patient that is choking. A choking patient needs immediate help to restore breathing. In adults, the most common cause of choking is food. Let's learn how to help a conscious and unconscious patient expel an object that's choking him. If you believe a person is choking, begin with scene assessment. Stop, think, and act. Since you're not likely to have contact with body fluids and time is important, you usually do not need personal protective barriers. Ask a responsive patient,
"Are you choking?"
If he can speak or cough, encourage the patient to cough until he expels the object. If the patient cannot speak or breathe, give the emergency responder statement and alert EMS. After the patient indicates he wants your help, you will either use back blows, abdominal thrusts, or chest thrusts to attempt to dislodge the object. To deliver back blows, take a position to the side and slightly behind the patient. Supporting the chest with one hand, lean the patient forward. Next, firmly strike the person between the shoulder blades with the heel of the other hand 5 times. Stop if the obstruction clears. If 5 back blows fail to relieve the airway obstruction, give up to 5 abdominal thrusts.
Choking?
Abdominal thrusts use residual air in the patient's lungs to blow the obstruction clear. Stand behind the patient with your arms around her waist. Find the patient's navel with one hand. Make the other into a fist and place the thumb side against the patient's abdomen slightly above her navel, like this. Put your other hand on top of your fist. Bowing your arms so you don't squeeze the patient's ribs, pull your hands inward and upward in a thrusting motion. If the obstruction is still not relieved, continue alternating 5 back blows with 5 abdominal thrusts. Abdominal thrusts may not be possible with some individuals, such as those who are pregnant or markedly obese. In these cases, provide thrusts in the center of the chest. Use your fist with the thumb inward and the other hand on top, just as you do with abdominal thrusts, but put your fist on the same site where you would perform a CPR compression. When you practice these techniques, be sure to simulate thrusting. Never perform thrusts on a person who does not have an obstructed airway. If the patient becomes unconscious, support her carefully to the ground, immediately activate the emergency services, and then begin CPR. Following the chest compressions, you should quickly look inside the patient's mouth to see if there is any solid material visible in the airway. If an object is seen, you should remove the object with your finger. If no object is seen or the object has been removed, you should proceed with 2 rescue breaths.
What happened? Greg cut himself on the saw. Can you call for help and wait outside for them till they get here and bring him back?
Okay.
Thanks.
Can I help with anything?
Yeah, could you get the first aid kit, please?
Yeah.
Thank you. Okay, Greg, try and elevate her here. Okay, try and keep your arm elevated here. Great, thanks. Great. Continue in area. Thanks. Okay, Greg. Put this on here. Okay. Hang in there, Greg. Okay, let's have a look at this.
The S of the Lifeline's ABCDs prompts you that after confirming the airway, breathing, circulation, and defibrillation if needed, you need to control serious bleeding. Serious bleeding can be life-threatening because blood carries oxygen to the body tissues. The body holds about 6 liters or quarts of blood. Losing even one can cause death. There are 3 types of bleeding depending on the type of blood vessel injured. Arteries are the largest vessels and carry blood from the heart to the tissues. Arterial blood spurts with each heartbeat and is bright red. Arterial bleeding is the most serious because the patient can lose a lot of blood quickly. Call the emergency medical service immediately for this type of bleeding. Veins lead from the tissues back to the heart. Venous blood is dark and flows steadily without spurts. Venous bleeding can also be life-threatening. If you cannot control it, contact the emergency medical service and monitor the patient's lifeline. Capillaries are tiny blood vessels between the arteries and veins where the blood and tissues exchange oxygen. Capillary bleeding tends to be slow and easily controlled unless the injury covers a large area. Monitor the patient's lifeline and contact the emergency medical service if necessary. Tell the patient that you're an emergency responder and ask if you can help. When the patient says yes, call emergency medical services.
Go call for help.
Since the patient is responsive, you have confirmed the patient has an airway, breathing, and circulation. Serious bleeding is usually obvious. Next, control the bleeding by using direct pressure. Put a clean cloth or dressing on the wound and apply pressure. If you have no dressing, use a piece of cloth or even just your gloved hand if there's nothing available. Maintain the pressure continuously. but you may periodically release pressure to see if the bleeding has slowed or stopped. In addition to direct pressure, you may also use a pressure bandage. While maintaining direct pressure, tie another dressing over the initial one. The patient may assist if able. If the dressing becomes blood-soaked, don't remove it. Instead, add another on top and continue direct pressure. Do not remove blood-soaked dressings. Although there may be regional variations, your instructor will advise you of these. Blood will clot in the dressing and slow or stop bleeding. Removing the bandages will disrupt this process. Shock is the body's response to serious injury or illness. It can be life-threatening and happens when not enough oxygenated blood reaches the body tissues. There may be too little blood because of serious bleeding, or it can happen when the body no longer regulates blood flow to the tissues. In shock, the tissues don't get enough oxygen. 9 signs and symptoms indicate shock, though some may occur with other injuries. They are mental confusion, anxiety, restlessness or irritability, altered consciousness, pale or bluish tissue, rapid, weak pulse, shallow but rapid labored breathing, nausea, vomiting, thirst, lackluster eyes, dazed look, and moist, clammy skin, sometimes with shivering. By the time you get to shock management, you will have progressed well along the patient's lifeline. You will have assessed the scene and applied your barriers. Through primary assessment, you would have alerted emergency medical service and confirmed airway, breathing, and circulation. There would be no need for defibrillation, or you would be providing CPR, and you would have handled serious bleeding. To treat shock, if the patient is responsive and you don't suspect head, back, or neck injury, put the patient in a comfortable position. If there may be head, back, or neck injury, don't move the patient and keep his head and neck immobile. In either case, cover or shade the patient to maintain his normal body temperature. If you've had to control serious bleeding, maintain control of the bleeding. If there's no reason to suspect head, back, or neck injury, elevate the patient's legs 15 to 30 centimeters, 6 to 12 inches. This shifts blood to the more critical chest and head areas. If oxygen is available, it can help a patient in shock. Some units are easy to use and require little, if any, training. Your emergency first response instructor may teach you how to properly use oxygen as part of your training. Spinal cord injuries can cause permanent paralysis or death. The spinal cord runs through the neck, down the back, and connects the brain to the rest of the body's nervous system. A break in the spinal cord makes it difficult for the brain to control the nervous system below the break. Injuries to the head, neck, or spine may injure or threaten the spinal cord. Moving a patient with a head, neck, or spine injury may make the injuries worse. Therefore, never move a patient with a suspected spinal injury unless absolutely necessary because of imminent danger. Conduct your primary assessment where you find the patient. You would only move the patient to avoid immediate further harm, such as if the patient were in the water or a burning car or building. You would also move the patient, if necessary, to provide CPR. You should suspect spinal injury with situations that cause injury to the head, neck, or spine. These include auto accidents, being thrown from a moving object, falling, especially from a height higher than the victim, a penetration wound, such as a gunshot, any severe blow to the head, neck, or back, An accident that includes hitting something head first, such as diving into shallow water, lightning strike, or any severe impact injury regardless of what part of the body was struck. 8 indications that a patient may have a spinal injury are change of consciousness, difficulty breathing, vision problems, inability to move some or all of the body, paralysis, headache, vomiting, loss of balance, tingling or numbness in the extremities.
Hello?
Following the ABCDs of the Lifeline, start with scene assessment. Conduct your primary assessment with the patient in the position you find her, unless the patient's safety is in question or her lifeline is in jeopardy, meaning you need to open the airway, deliver CPR, or control serious bleeding.
May I help you?
Put on your barriers and contact emergency medical services.
Call for help.
The patient must be on her back for CPR. If she's not already on her back, you'll have to turn her while minimizing risk to her spinal cord. You want to stabilize the head and neck so that as you turn the patient, they stay aligned and unmoved relative to the spinal column. If you have someone who can help, have him hold and stabilize the head as you roll the patient all at once, keeping the head, neck, and spine together as a unit. If you're alone, you'll stabilize the head yourself. The log roll technique helps you do this. Tuck the arm away from you under her hip, and while supporting her head, roll the patient toward you. Gently ease the patient onto her back and continue with the ABCDs by opening the airway, rechecking for breathing and circulation, and then starting CPR as necessary. During your primary care course, your instructor may also have you practice one or both of the 2 recommended primary care skills: automated external defibrillator use and emergency oxygen use. Depending on local guidelines, restrictions, or laws, your emergency first response instructor may or may not be able to offer a skill development session on these recommended primary care skills. Now that you understand the 8 primary care skills, let's apply them to some realistic situations. Watch as the emergency responder in each scenario adapts the Lifeline ABCDs to the realities of the situation.
Grandma? Are you okay? What happened? What's wrong? What happened? Hang on, everything's gonna be okay.
Stop, think, and then act. Is there a hazard here? The emergency responder sniffs for gas and confirms the gas stove is turned off.
Grandma, do you need help? It's okay, I'm an emergency responder. May I help you? Jimmy, come here quick! It's okay. What's wrong? I don't know. Something's wrong with Grandma. Go call for help. Tell them we have an emergency and then come back and tell me what they say. I'll call and come back.
The emergency responder gives the medical statement and gets emergency care on the way. The emergency responder monitors the patient's lifeline. She's breathing, confirming airway, breathing, and circulation. There's no evidence of bleeding.
Help will be here soon. Help me put her in the recovery position. Put her leg a little bit forward. Go get the pillow and blanket on the couch. Go wait for the ambulance outside.
The emergency responder treats for shock and continues to monitor the patient's lifeline until help arrives.
Okay. Help is on the way. Don't worry.
The emergency responder stops, assesses the scene, thinks, and then acts.
Ken. Ken, are you all right? Ken. Front desk, this is Jocelyn. I'm in the library and there's something wrong with Ken. Call emergency medical services immediately. No, I'll manage. You wait for the paramedics and then bring them back here to us. Hurry. Ken? Ken, are you okay? Ken, it's Jocelyn. I'm an emergency responder. May I help you? Ken? Ken, are you all right?
The emergency responder finds the patient non-responsive and turns him so she can begin CPR by opening the airway and checking for breathing. The emergency responder provides rescue breaths and chest compressions until emergency medical personnel arrive.
One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9, 10, 11, 12.
The emergency responder stops, assesses the scene, thinks, and then acts.
Ken. Ken, are you all right? Ken. 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 Ken, are you okay? Ken, it's Jocelyn. I'm an emergency responder. May I help you? Ken, are you okay? Ken.
The emergency responder finds the patient non-responsive and turns him so she can begin CPR by opening the airway and checking for breathing.
Front desk, this is Jocelyn. I'm in the library and there's something wrong with Ken. Call emergency medical services immediately. No, I'm okay. Just wait for the paramedics and bring them back here to us, and hurry.
The emergency responder provides rescue breaths and chest compressions until emergency medical personnel arrive.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9, 10, 11, 12.
A medical emergency with more than one victim and only one emergency responder requires some thought. You can only do so much, so do the best you can. Stop, think, and then act.
Yeah, I need to report an auto accident on the corner of Alton and Pacific. It looks like you might have a couple injured passengers. Yeah. Yeah, okay. Sit tight, all right? Help's on the way.
The emergency responder approaches the scene cautiously, keeping himself safe and watching for hazards as he approaches the scene.
Hey, my name's Matt. I'm an emergency responder. May I help you?
Yes.
Well, where do you hurt?
On my head. I'm okay.
Okay, I want you to try not to move it, okay? Let's wait till the medical crew gets here so they can check you out. All right? It looks like your passenger may need some help, so I'm gonna go take a look at her. So just sit tight and relax, all right? Okay. I'll be nearby. All right. Hey, how you doing? You okay? You all right? Just relax, okay?
The emergency responder follows the second patient's lifeline and controls serious bleeding. Notice that he continues to monitor the ABC parts of the lifeline while maintaining pressure on the wound.
How's your head feel?
The same.
Okay, just relax. Help's on its way.
The emergency responder asks the question as a simple way of checking the first patient's lifeline.
Is there anything that I can do?
Are you a trained emergency responder?
No.
That's okay. You know what? You can put on this extra pair of gloves I have here.
Okay.
Try and lay still, okay? Keep your head still for me. What I need you to do is I need you to put pressure on this wound here, okay? If you need another bandage, go ahead and take one out of that box and put it right on top of this, all right? Keep pressure on the wound the whole time. Okay, so when I take my hands off, go ahead and replace them with yours, okay? Here we go. Good.
The emergency responder continues to monitor the ABCDs for both patients until the emergency medical service providers arrive.
There you go, lay still. Okay, keep pressure on there.
Okay.
Okay, try and relax, okay? I'm gonna hold your head until the ambulance gets here.
All right.
Sit tight, all right? The guys are here.
How many people do we have in the vehicle? One?
Just two.
Two, that's it? Anyone ejected? Anyone else in the vehicle? No?
Came on these guys.
No, that's it. Okay, what do you have right there?
As you saw, having more than one person at the scene increases the aid available. By encouraging your family and friends to complete the emergency first response courses, you increase the chances there will be more than one emergency responder at hand in a medical emergency. As an emergency responder, you play a crucial role in a medical emergency. In life-threatening emergencies, you provide the critical first links in the chain of survival that summons emergency medical aid and monitors the patient's lifeline, providing aid that increases the chances of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability. Most emergency responders will never need their skill, but practicing them and reviewing this program will help you be ready to reach out and help another in need should you ever need to. Now that you've completed Emergency First Response Primary Care, you're ready to complete the Secondary Care course.
I got dizzy about a half an hour ago.
As you recall, this is Secondary Care because it follows the primary care of assuring the ABCDs of the patient's lifeline. And, as you recall, primary care never stops. You constantly monitor the patient's lifeline. However, if emergency medical services are either delayed or unavailable, you'll need the following secondary care skills. You'll practice 4 secondary skills: injury assessment, illness assessment, bandaging, and splinting for dislocations and fractures.
No. What about back here? Nothing?
Injury assessment helps you identify injuries that affect the patient. You can attend to some of the injuries, and you will report them to emergency medical personnel once they arrive. Remember that you always begin with primary care and the ABCDs. Assess the scene. Stop, think, and then act. Apply your barriers by putting on your gloves. Check for patient responsiveness, then give your responder statement. Contact the local emergency medical service if at any time you begin providing primary care.
My name is Eileen. I'm an emergency responder. May I help you? Okay, let's call for some help.
Remember that you always begin with primary care and the ABCDs. Assess the scene. Stop, think, and then act. Apply your barriers by putting on your gloves. Check for patient responsiveness, then give your responder statement.
My name is Eileen. I'm an emergency responder. May I help you?
Contact the local emergency medical service if at any time you begin providing primary care and have found the patient is not breathing. Be sure that you don't need to attend to anything on the patient's lifeline before beginning the secondary injury assessment. Start by telling the patient that you're going to check for injuries. Hold the patient's head and ask the patient to keep her head still and answer questions verbally rather than nodding or shaking her head. It helps to ask questions that she can't answer with a yes or no. You start your assessment at the head and work to the patient's toes. If the patient complains of head, neck, or back pain, stop the assessment immediately and keep the patient immobile until help arrives. Feel for deformities on the patient's face with a gentle touch. Check the ears and nose for blood or fluid. See if the patient's pupils are the same size and have her follow your finger with her eyes without moving her head or neck. Check the eyes for smooth tracking. The eyes should track together. Also, check pupil size. Feel the skull and neck for abnormalities. If the patient complains or you find something, stop the assessment. Slide your hands over the shoulder blades and gently push against the back. Press inward on the shoulders and run your fingers over the collarbones to the center. As you perform these steps, you're looking for irregularities or blood, or for the patient to mention pain or other unusual sensations caused by your touch. Stabilize the patient's arm with a hand on the shoulder and slide your hand gently down the upper arm, elbow, and wrist. Repeat on the other arm. Ask the patient to wiggle her fingers on both hands and squeeze yours to check for paralysis or weakness. Inspect the chest for deformity. Place a hand, palm in, on each side of the patient's rib cage and gently push inwards. Gently put your hands under the patient to check the spinal column. Cover as much area as possible without moving her. If you find any irregularities, stop the assessment. Ask the patient to tell you if she feels pain. Gently push on the patient's abdomen on the right, left, and above and below the navel. Move your hands over the hip bones, palm inward, and gently push on the hips. Starting at the thigh, slide a hand down the upper leg, knee, lower leg, and ankle. Ask the patient to wiggle her toes and press her foot against your hand. Repeat this with the other leg. After your assessment, you will attend to the injuries you can. Otherwise, continue to monitor the patient's lifeline and report what you found during the assessment to emergency medical services personnel.
It'd be fastest if you come with me.
Illness assessment helps you find and report medical problems that affect the patient's health and may aid with treatment. You'll assess the patient by asking questions and by checking the patient's breathing, pulse, temperature, and skin. In class with your instructor, you'll practice an illness assessment on a healthy person. Assessing a healthy person may help you recognize differences later if you assist an unhealthy person. As you've learned, you start with primary assessment. After giving the responder statement and assuring the patient's lifeline, get something to write on so you or someone assisting you can record what you find. There is an illness assessment record sheet in your participant manual. To help you remember how to begin an illness assessment, use the mnemonic SAMPLE. The S in SAMPLE stands for signs and symptoms. A stands for allergies. M stands for medications. P stands for pre-existing medical history. L stands for last meal. And E stands for events. The S stands for signs and symptoms. Signs are something you, the rescuer, sees. Symptoms are something the patient tells you he's feeling. Ask the patient how he feels and what happened right before getting ill. Ask, how do you feel now? Next, you'll check the patient's pulse. Find the pulse on the patient's wrist. Feel the pulse with your fingers, not your thumb, and count for 30 seconds, then multiply by 2. The typical adult pulse rate at rest is 60 to 80 beats per minute. Next, you'll check the patient's respiration. As you do this, remember the typical adult breathing rate at rest is 12 to 20 breaths per minute. Someone breathing markedly faster or slower may have a medical problem. To check the breathing rate, watch the patient's chest or place a hand on it while timing for 30 seconds, then multiplying by 2. Attempt to check a patient's respirations without them knowing you are doing so. Listen for wheezing, gurgling, or high-pitched noises. Note if the patient complains of short breath, dizziness, lightheadedness, chest pain, or numbness, or tingling in the arms or legs.
Numbness or tingling, any of the extremities or...
Next, check the patient's temperature and moisture. Feel the patient's forehead with the back of your hand. See if it's warm, hot, cool, moist, clammy, etc. Check the patient's color. Is it pale, ashen, reddish, bluish, or yellowish? Does it have blotches? If the patient has dark skin, check for color change in the nail beds, lips, gums, tongue, palms, whites of the eyes, and earlobes. Usually, an adult at rest should have skin that's warm and dry to the touch. Noticeable changes in temperature, moisture, and color may indicate problems. Next, check the patient's eye pupils. Are they enlarged? Small? Unequal? Any of these may indicate problems. Also in the mnemonic SAMPLE, the A stands for allergies. Ask the patient about allergies to medications, insects, food, or the like. Ask the patient, have you been exposed to something you are allergic to? While talking to the patient, look for Medic Alert bracelets. Next, the M stands for medications. Ask the patient if he takes any medications. If so, ask, what medication do you take? Did you take it today? How much did you take and when? If possible, get the patient's medication so you can turn it over to emergency medical personnel when they arrive. The P in SAMPLE stands for pre-existing medical history. Ask the patient if he has any medical conditions like asthma, epilepsy, heart conditions, or diabetes. The L in sample stands for last meal. Ask the patient, when did you last eat? What did you eat?
And any other events that you could think of that led up to this?
The E in sample stands for events. Ask the patient about or note the events that led up to the illness. Bandaging helps control bleeding, immobilize the injury, and reduce dirt or other contaminants from entering a wound. It's a skill that can range from life-saving in the case of serious bleeding to simply helping the patient feel more comfortable. After attending to primary care and injury assessment, you may apply roller bandages directly over a sterile dressing on a wound. As you recall, once you have a dressing in place, you don't remove it. Start below the wound and wrap upward over it. Wrap tightly enough to hold the bandage snugly in place, but loose enough that it doesn't restrict circulation. Leave fingers and toes exposed so you can check them for proper circulation. If you're bandaging a foot, start with a couple of turns around the ankle, then over the injury site on the foot. Similarly, start a hand bandage around the thumb and wrist. Elbow and knee injuries normally call for wrapping above and below the joint to stabilize the injury. Triangle bandages support injuries to the arm, ribs, or shoulder. Start with the bandage top over the shoulder on the affected side. Bring the arm over the bandage, then bring the low end of the bandage up behind the neck and tie it off. Support the arm and hand with the fingers showing. If you suspect broken ribs, tie a second bandage to hold the arm against the injury side of the chest. This helps immobilize the entire affected side of the torso. Splinting immobilizes broken bones and dislocations. This reduces the risk of further injury and serious bleeding and lessens the pain for the patient. You may need to apply a splint if emergency medical care is either delayed or unavailable. When needed, splinting follows all primary care concerns, injury assessment, and any necessary bandaging. Splint the injury in the position you find it. Don't try to straighten it, and try to minimize moving the affected limb before you splint it. You can use a commercial splint or improvise with almost anything rigid. Choose a splint long enough to immobilize joints above and below the injury. Pad the splint with extra padding inside body curves and hollows for even, comfortable contact with the splint. Bandage the splint in place using a roller bandage, adhesive tape, or other material available. It should be snug enough to immobilize the injury, but not restrict circulation. Check the pulse before and after splinting for blood flow. Gently squeeze the patient's fingertips or toes and check that the nail beds immediately regain their color. If not, or there's no pulse, loosen the bandages so normal circulation returns. If the fracture involves an arm, you can put the arm in a triangle bandage after splinting. One important point, do not splint if doing so increases patient discomfort or pain. Now that you understand the 4 secondary emergency first response skills, let's apply them to some realistic situations. Note in each scenario that the emergency responder first attends to the lifeline ABCDs and confirms that EMS is either delayed or unavailable before moving into the secondary skills. The emergency responder takes a moment to assess the scene. He stops, thinks, and then acts.
Hey there. Looks like you took a little spill. My name's Pat Jones. I'm an emergency responder. May I help you?
Yeah, I think I broke my arm.
Yeah, anything else hurt here?
Because the patient is responsive and talking, the emergency responder knows that the patient has an open airway, is breathing, and has a heartbeat.
Okay, just relax and try not to move, okay? While I try and get help.
Okay.
No service. Guess I won't be able to get emergency medical services here. But it's okay. I can assist you. Try not to move your head at all.
Okay, all right.
Let me take off your glasses, okay?
All right.
You doing okay?
Yeah.
All right, open your eyes and try not to move your head while you look at my finger. Perfect. Let me check your ears for you. How's your head feel?
It feels good.
Any pain when I'm feeling this?
No.
What about back here? Nothing?
That's fine, that's fine.
Okay, how do your shoulders feel?
I feel okay.
Okay. Any pain?
No.
Nothing?
No.
Okay, how you doing, okay?
Okay.
Don't move your head. How's that feel?
That's okay.
I'm gonna check your spine for you, okay? Tell me if you have any signs of pain. Anything?
No.
Okay. And check your abdomen now. Does that hurt?
No.
Here?
No.
Here?
That's okay.
Here?
It's good.
Okay, I'm gonna check your hips. How's that feel?
It's okay.
All right, I'm gonna go down to your legs now. Feel any pain here?
No.
Anything?
No.
Wiggle your toes for me. Okay, let's do the other side. How's that feel?
Feels good.
Can you wiggle your toes for me? Okay, which arm hurts?
It's my right arm.
Okay, I'm gonna leave that alone for now, and I'm gonna bandage this cut first. Then I'm gonna splint your other arm, okay? That should make you more comfortable, all right?
Okay.
You get the splint, I'll be right back. I got a blanket for your head, okay? Let's move this out of the way. I'm gonna easily move up your head. Okay, lift it up slightly. Okay, set it down. How's that feel?
That's okay. It's good.
Okay.
It's good.
Let me see. Let me see this arm. Try not to move your head, okay?
All right.
All right. So what were you doing out this morning? Just going for a bike ride?
Yeah.
Yeah? What'd you do? Hit a rock? Didn't see it or something?
I don't know.
Yeah. This should make you feel a bit better, okay, buddy? What's your name?
Eric.
Yeah? How you feeling?
It's just my arm, man.
Yeah. Looks like you took a little bad spill on that side. I'll get to it in just a second, okay? Doing okay?
Yeah.
All right. Just about done here. Okay, I'm gonna splint your arm now, okay? You help by moving your wrist area, and I'm gonna move your elbow up, and I'm gonna slide the splint underneath your arm, okay? At the count of 3. 1, 2, 3. I know it hurts. This will make it feel more comfortable. Good. Let's move it across your chest slightly. Okay, I'm gonna tie the splint now, okay? You doing okay?
Yeah, yeah.
All right, I know this hurts, but it will feel better. All right. Look, we're pretty far away from emergency medical services, okay? And I can't get any service down here. I can take you, or I could go get help. I think it'd be fastest if you come with me. Are you comfortable with that?
Carrie,
What?
are you okay?
Oh, hi, Marino. Just something I ate.
Well, you don't look well at all. Look, I'm an emergency responder. Can I help by taking your pulse and other things just in case?
Yeah, but it's really just lunch.
Let's see, well, what did you have for lunch?
The usual. Salad with dressing.
Well, your pulse is 110 and your respiration is 22. When did you start to feel ill?
About an hour ago.
And how do you feel now?
About the same.
Are you taking any medication?
Blood pressure stuff.
Have you taken any today?
I took it at lunch. I just started a new prescription.
Do you have the prescription with you?
Yeah.
Carrie, have you been doing any exercising in the last minutes before I came in?
No.
Well, your pulse is racing, you're breathing heavy, and you're cold and clammy. As a precaution, I think we should get you checked out.
I don't think it's anything.
I'm sure it's not, but just in case.
Okay.
Yes, can you call the emergency response team to Carrie Tull's office? Yes, he's feeling more than mildly ill. No, I'm okay here. Just make sure you bring them back here as soon as they arrive.
As an emergency responder, you play a crucial role in a medical emergency. Your primary care response skills are the critical first links in the chain of survival that summon emergency medical aid and monitors the patient's lifeline, providing aid that increases chances of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability. Your emergency first response secondary care skills can benefit patients by alerting medical personnel to conditions that need attention, by reducing further injury, and by increasing patient comfort. As you've already learned, few emergency responders ever need their skills, but if you ever do, you'll be ready to reach out and help another in need.